Welcome to Med Evidence, where we help you navigate the truth behind medical research with unbiased, evidence-proven facts, powered by Encore Research Group and hosted by cardiologist and top medical researcher, Dr. Michael Koren.
Hello, I'm Dr. Michael Koren, hosting our second in our series on advanced lipid profiles with my good friend and colleague, Dr. Al Lopez. And we've been talking about what, in fact, an advanced lipid profile is and how this can now perhaps be applied to taking better care of our patients. But we left our last session talking about what we like to call the really bad cholesterol, and that's lipoprotein-a. And both Al and I have been very involved in clinical research on this particular problem. So Al, just brief everybody, give them an overview of what Lp(a) is, lipoprotein-a is.
So Lp(a) is a protein that is genetically mediated. So it goes from family to family and affects 1 in 5 people globally, but it can be passed down to half of your children.
So it's autosomal dominant inheritance.
Correct.
So if a parent has it, there's a 50-50 chance that a child will have it.
This is correct. It's a very bad actor because unfortunately, up until recently, we didn't have anything to really treat it with. Nothing really worked effectively. We know that diet and exercise didn't really change Lp(a).
Not at all. How about statins?
Statins actually may increase it, but the amount that it raises is fairly insignificant, and it doesn't really make you
Well, it certainly doesn't help.
It doesn't help. It doesn't. Theoretically, in the scheme of things, it's insignificant.
And in fairness, just to be fair, it does lower other lipid problems, so it reduces overall risk of somebody with high Lpa, but it doesn't change Lpa in of itself.
Well, it's true, and what I kind of explain to patients is it's almost like taking metal as a substrate. If you take metal out of salty water, it's not going to rust. Mm-hmm. So there's less. You have many ways to get arterial disease or vascular disease, and LDL is probably the biggest one that we can fix, and probably the biggest one we have. Lp(a) is a very bad actor. Right. But if you can get rid of one variable, then get rid of it, please.
And that's an important point, is that we haven't focused as much on Lpa as we might have otherwise, because we didn't have any way specifically to treat that lipoprotein. So we just treated other lipoproteins more aggressively. So
Agreed.
A good way to just think about it. Anyhow, so jumping back into Lpa, are there different types of Lpa?
There are different isoforms. Some are much more atherogenic or plaque-producing than others. We're working on trying to figure those out. We also know that the isoforms that are more atherogenic, if they become oxidized, we make them more atherogenic. So if we, as we talked about in the last segment, oxidize LDL, there's an interesting research project, again, at University of Southern California, that if we oxidize LDL, it may actually activate, I guess that's a bad term, but activate Lp(a) to be more plaque producing and more atherogenic.
And Lp(a) actually has LDL in it. It's sort of LDL plus.
Right. Plus.
Yeah, and I think we have a slide or a picture of what an Lpa molecule looks like. And you have this squiggly part on the outside of the lipoprotein core. And that's the part that probably determines how dangerous the molecule is.
Yeah, and it's a bad actor. It's pro-clotting or prothrombotic. It increases the risk of vascular disease, whether it's carotid, heart, or in the legs and peripheral vascular disease. We know that it increases aortic stenosis at a young age, so that valve tightens very quickly.
Yeah, interestingly, in Caucasians, but not African Americans.
Yeah.
It's a very interesting genetic element is African Americans have a pretty high incidence of Lpa compared to other races, but they don't get aortic stenosis for some reason.
And it's pro-inflammatory, so it sets up that whole pro-inflammatory cascade, which is just as dangerous as high LDL is. Mm-hmm. So that's important to know as well.
Right. And so what's a dangerous level of Lpa?
We're thinking probably over 100 definitively, but there's some data showing 50 to 75 is probably significant that you want to pay attention to it.
And just explain the whole unit controversy to people, because 100 is a little bit different depending on the units.
Yeah. So we can look at it 2 different ways, from millimole to deciliter or milligrams to deciliter. And unfortunately, labs do it different ways, and we're trying to find a uniform standard of measuring that unit.
Right.
And sticking to that, so we're all speaking the same language.
Sure. An abnormal lipoprotein(a) level would be considered greater than 30 milligrams per deciliter or greater than 75 nanomoles per liter.
Yeah. And it's interesting because you can't calculate from one to the other very well. There isn't a great formula to calculate that and make it, so you can't convert it.
Yeah,
it doesn't work well.
So if you have levels and a genetic risk, then certainly you get worried. But what's been your clinical observation of LPA? Does everybody with a high LPA have problems, or is there some heterogeneity to that?
No, that's what really makes it very interesting, and we really need to continue the research on it. That just because you have high Lp(a), and I have several patients with very high Lp(a), 200, 300, 350, and there's no sign of cardiovascular disease. We've done cardiac ultrasounds with them; they're wide open. This woman had chest pain, and she had a stress test, and stress test she blew it away. She went back in, had a catheterization. She had wide open coronaries, well, minimal disease anyway. And her lipid profile wasn't that bad. I got her LDL from over 175 down to below 70 at this time with lifestyle changes, but actually she's on a statin, which made a big difference.
Sure. So what can we do about LPA?
That's the bugaboo. We have 2 drugs that we now have that we're researching, and we know that it drops them markedly, 90% it seems.
Yeah, 2 drugs in late-stage clinical trials.
Late-stage clinical trials.
A bunch in early trials.
Yeah. And they're long-term studies, so there's several-year studies looking at outcomes as well and seeing if we actually can reduce event rate, not just lower the number, right? So lowering the number is one thing, that's great, but if it doesn't change event rate,
correct,
why bother?
And you're personally involved in these studies.
Yes, as you are a personal investigator, and it's been a long time passion of mine looking at this Lp(a), and now very excited to be part of research team, hopefully making a change in that.
Now these drugs do lower LPA, right?
They do.
Yeah.
Markedly, like 90%.
Plus, yeah.
We are looking at some other things. We do know that there's other drugs that also lower Lp(a). If I may, PCSK9s will do that.
Not as well.
Not as well, about 28 to 24 to 32%, somewhere in there.
Mm-hmm.
But it's not marketed and it doesn't have an indication for that.
Yeah. So PCSK9 drugs work great on LDL cholesterol.
Yep.
And they work by increasing the effectiveness of the LDL receptor. Actually, they increase the density of the LDL receptor in hepatocytes and literally squeeze cholesterol out of the circulation. And we don't know why they work for LPA, though, because we don't think that LPA is removed from the body through the LDL receptor.
No, and as a side, they're also anti-inflammatory. So, when they initially did the study on it, they showed inflammatory markers all came down markedly, as well as ApoB.
For the PCSK9s?
For the PCSK9s, but yet we don't have an indication for that. So it may do it, but you can't write it for that.
Sure.
So you're kind of stuck, you know. But if you have high LDL and have a high Lp(a) and you're on a PCSK9, it'll give you some reduction. Not as much as we want, but some reduction. And then we also have the small interfering RNAs, and I'd like you to talk about that because you were the first author on the first paper on silencing RNA, dropping Lp(a) like 95% or so
that's pretty impressive.
in Nature.
Yeah, it was in Nature Medicine. Yeah, thank you for the plug. But in any event, we have these technologies now. These are gene-regulating technologies, whether it be an ASO, an antisense oligonucleotide, or a small interfering RNA, are both ways of regulating gene expression. And by regulating gene expression, we're able to knock down these levels by 90% or more. It's really impressive.
This is, the older I get, the more we get into everyday science fiction. Stuff we read about as kids are actually happening today. So, this was a fantasy when we were younger to think that we could do something like this. And now we're able to do this in medicine and in science and every day. It's pretty incredible.
It's pretty impressive. So, those 2 types of products are in late-stage clinical trials, looking at whether or not they'll affect outcomes, as you point out. But we're also working with companies that are earlier in the process. And it'll be interesting. It'll be interesting to see if anybody can come up with a solution that involves a pill. And people are certainly working on that in early stage ideas at this point.
It's an interesting concept. If you go back to 2002 articles up to a year ago, 2023 articles, there's many articles that show that irrespective of how low you bring LDL, and again, that number, how low you get to, changes every so many years, right? It's like a limbo contest. It gets lower and lower and lower every year. But irrespective of how low you bring it down, and with optimal treatment, there's still a percentage of people that if you don't look at an advanced lipid, that you're not going to find their hidden risk
Right.
for a cardiovascular disease.
So the take-home message is, if you're listening to this and you have an LPA problem, the current drugs on the market will get you down 25% at best.
Yeah.
But if you get involved in a clinical trial, you may get that LPA down to 10% what it was, or even less. So something to think about, and we are actively involved in clinical research. The other little pearl is that some people, when you put them on statins, their LDL isn't affected that much, and you wonder what the heck's going on, and what could it be?
So they're probably using an older methodology of looking at the lipid profile, and that includes Lp(a). And so that LDL, when you're measuring it, they're measuring Lp(a) with LDL, and if it's not lowering, you're not lowering the Lp(a), because statins don't lower Lp(a), they raise it. So those statin intolerant, as far as not lowering, or statin
So some of the LDL may
ineffective.
actually be LPA.
Yeah, it's
And
Lp(a).
Unless you're measuring the LDL directly,
Yeah.
you're not going to get that information.
So that's immediately should be a light bulb in the back here saying, maybe I do have elevated Lp(a). There's two camps now that, we should only screen high-risk patients for Lp(a). I'm of the camp that I think everybody should be screened for Lp(a), and at a younger age better. And so in Europe, they're starting to do that in certain countries, looking at young adults, early teenagers, and even kids, and looking at their Lp(a) levels to try to mitigate that risk over time.
Right. And so we started our last session talking about advanced lipid profiles and why they're important. And part of that discussion about measuring lipids is this concept of direct versus indirect measurement of LDL.
Yeah.
And obviously, if you're measuring LDL directly, you don't run into this problem with overlap with LPA.
Right.
And so explain to people what that means, the difference between direct and indirect.
So when you're measuring indirect LDL, there was originally the formula was done by a 1975-6 Friedewald formula, which was never intended to screen the average person for cholesterol. It was intended to screen for people that were heterozygous hypercholesterolemic patients, so people with high cholesterols. And it doesn't give you an accurate LDL because it's predicated on a fasting lab draw, and it's calculated off of a triglyceride level.
And it's also an estimate. So
it's a guesstimate. So you're estimating an estimate.
Exactly. You're not actually measuring LDL. Yeah. You're measuring, just so everybody knows out there, you're measuring total cholesterol, which we're good at. You're subtracting HDL, and then you're subtracting triglyceride-rich particles using sort of a very loose argument that number should be triglycerides divided by 5.
So I'm not of the camp that every single person needs a direct LDL, but I think that there's a huge number of patients that do need a direct LDL. People with high triglycerides, people that are not fasting. If they're not doing their labs and I have them in the office and it's 2 p.m, they ate, it doesn't really matter. I'll measure a direct LDL on them and then do the lipid profile and maybe an advanced lipid profile if indicated. So I can get a direct LDL and know what they are, irrespective if they're fasting or not.
Mm. Yeah, so the technology for direct LDL measurements is also getting better. So now there are analyzers and chemical assays for direct LDL. It used to be you have to go through what's called ultracentrifugation, where you have to spin this down, and we call that also beta quantification. And that was a pretty expensive process. But I think it's how much is it now for direct LDL?
Direct LDL, I think it's like $25, $30.
Yeah, it's come down a lot.
I mean, it probably is even cheaper than that.
Yeah, it used to be a couple $100. So
yeah, and it's actually, if you have the right code, if you have cardiovascular disease or hypertension, I don't know why hypertension, but hypertension, or you have high triglycerides, then direct LDL is acceptable.
Okay.
So you can get it paid for at that point. And so those advanced lipid profiles really aren't, and direct LDLs are not that expensive anymore, and are very, very, very well covered.
Beautiful. Well, we're going to now move into the clinical space for our next session and really talk about real patients and how we might deal with them.
Thanks for joining the MedEvidence Podcast. To learn more, head over to medevidence.com or subscribe to our podcast on your favorite podcast platform.